Hi, this is Elliot Fishman, and welcome to the January 2025 CTisus quiz. It's the first quiz of a new year. We have 10 excellent cases for you. I hope you enjoy them. And without further ado, let's get started. The most likely diagnosis in this patient with left upper quadrant pain is, well, we see a large mass, and I guess if you didn't have choices, you could say, could it be pancreas? Could it be adrenal? Could it be a retroperitoneal sarcoma? But when you look at the choices, I'm telling you it's an adrenal mass. Now, adrenal myelolipomas can be large, though large might be 8 to 10 cm. Also, they have macroscopic fat. There's no evidence of macroscopic fat in this lesion. Occasionally, they can bleed, and so you may not see the fat all that well, but this does not look like a myelolipoma. There's too much solid component. Adrenal ganglionomas are very uncommon lesions. They're large, they're hard to diagnose, they're typically solid, though occasionally they'll be of lower CT attenuation because they're neurogenic type tumors. You see some areas of lower attenuation here, but one would have to admit the dominant mass is solid, but it's a possibility. Adrenal adenomas rarely get this large in their low attenuation, though they can, of course, bleed. But this looks too solid. Pheochromocytomas can be larger, but they're typically vascular. They can bleed, they can have cystic spaces. You can have cystic pheos, but this is a solid mass. The truth is, if I looked at this lesion, my first thought would be an adrenal cortical carcinoma. Metastasis in a patient with hepatoma, perhaps, where they get large mets, or melanoma would be another possibility. Though in those cases, if one met gets this large in the adrenal, there are usually bilateral adrenal lesions. Well, at the end of the day, this patient went to surgery, and it was a ganglionoroma. They're rare tumors, but they do occur. Again, often lower attenuation, can be smaller, can have calcifications. But this is just a difficult case, and what a way to have a new case to start a new year. The vessel most involved with coronary arterial disease in this patient is well, I gave you all the vessels, but if you look at the images on the MIP, as well as on the 3D cinematic rendering, you can see the disease is most marked in the patient's LAD with calcified and non-calcified plaque present. I think I gave you this case because I really like the 3D imaging. It's not the right coronary. In fact, you don't really see the right coronary to any degree. Circumflex you see, but it's not the circumflex. Circumflex does have disease, as does the left main coronary artery. But at the end of the day, the vessel that's most involved is the left anterior descending coronary artery. The cause of this patient's bowel obstruction is, we know there are many causes of bowel obstruction, and in fact, adhesions is the most common. What I see here is a defect in the abdominal wall. There's some dilated bowel here, and then there's a loop that gets narrowed, and you see the findings in the subcutaneous tissues. Better seen on the sagittal view. You see how this loop goes through the defect and then is narrowed here. Now, when I look at hernias, whether they're umbilical hernias, or peristomal hernias, or inguinal hernias, I always say if I see the bowel and it's thickened, or if I see fluid around the bowel, or if I see inflammation, or if I see all of the above, I would tell the surgeon I'm worried the bowel is ischemia, the patient needs surgery. In this case, you can see the bowel has some fluid around it, there's some stranding. I would have to worry this patient will develop ischemic bowel and this patient needs surgery. But again, getting back to the cause of obstruction, A, adhesions. I don't see any adhesions. I don't see a small bowel tumor. This is not the look of a twist or a closed loop obstruction. Rather, the best answer is D. It's small bowel obstruction due to an umbilical hernia. A very nice example, also showing you the value of the sagittal view, how much easier it is to look at the process in question. In this patient with lower back pain and fever, the best diagnosis is, well, let's first look at the images. What I see is the right kidney is enlarged, and there are multiple low-density areas going central to peripheral in the kidney. It doesn't have the look of a tumor. It has the look more of infection or infarction. Infarcts are usually very sharply demarcated, can be single or can be multiple, can be unilateral or bilateral. Similarly, infection can be focal or diffuse, can be unilateral or bilateral. This is, of course, not acute pancreatitis. The pancreas looks good in this study. Infarction we consider, but the way the low density is to the periphery, the branching of it, the enlargement of the kidney, and the history, I would favor infection. E. coli is the most common infection. And then lymphoma can give you solitary or multiple renal masses, can be unilateral or bilateral. So at least you could consider lymphoma as an infiltrating process. But at the end of the day, with the history and with the CT appearance, my favorite diagnosis would be C, renal infection, and this was due to E. coli infection. The patient possibly could have passed a stone, but I do not see evidence, or a stone disease could have been the source in part for the patient's infection. The most likely diagnosis in this case is, well, when you look at the images, and it shows nicely on the volume rendered 3D map, you can see the opaque density in the junction of mid and proximal femur, and then a bit more distally. These are all artifacts from foreign bodies, which were gunshot wounds. You can see the SFA is followed down, then it abruptly stops, and you can see active contrast extravasation. More distally, the SFA to popliteal is seen. You don't see an obvious fracture, though there could be one. This is not the best rendering. And on the axials, you see the tracking of the bullets, and then you see the active contrast extravasation from the SFA. So let's go back to the case. Best diagnosis, it's not a femur fracture. We don't necessarily see one. It's not going to be a gunshot wound without the source of bleed because I can see the SFA and where it's stopped. Now, occasionally you can see stoppage of a vessel like the SFA in a gunshot wound due to spasm, but this is not spasm because you can see the active bleeding very nicely on the axials on the 3D mapping. So the best answer is B, a gunshot wound with active bleeding from the SFA, and this patient went to surgery. The most likely diagnosis in this 30-ish-year-old is, you can see I'm giving you choices of all acute processes, but what do we see? We see a dilated appendix with stranding, and here it is here with maybe a small appendolith distally. There's inflammation, there's a dilated appendix. This is not a Meckel's diverticulum, which can present very similarly in the same area, though Meckel's is usually further away and it's a blind pouch. It's not this tubular structure that communicates nicely with the cecum. This is not cecal diverticular disease with one diverticulum that's 5 centimeters long, but that's always a possibility of right lower quadrant pain. An ileal diverticular disease, whether it's diverticular disease or diverticulitis, can occur in any portion of the small bowel, but it can occur in the terminal ileum, simulating appendicitis or diverticulitis. But in this case, we see the appendix, which is sometimes hard to see. We can see it's inflamed, and we know the diagnosis is acute appendicitis. The most likely diagnosis in this case is, well, you can see a subtle mass infiltrating the patient's right lobe of the liver. On arterial phase, you can see that there's involvement and early filling of the portal vein, so there's AV shunting. And on the MIP image, you can see some of the neovascularity and the stretching of the vessels. So we're dealing with a tumor that's vascular, though not as vascular as some tumors we're used to. Cholangiocarcinomas typically are associated with dilated ducts and are hypovascular, so I don't like a cholangio for this one. Colon cancer metastatic is typically hypovascular. This lesion is just too vascular. With metastatic colon, you'll typically see the lesions better or best or only on the patient's venous phase, not arterial phase. But you can see them in arterial, but they're not going to be vascular like this case. Metastatic neuroendocrine tumors are often vascular, but typically more vascular than this. They can present with a solid mass in the liver, but usually it's multiple lesions. I don't see anything else, so I don't like that diagnosis, but it could be a possibility if I told you the patient had a carcinoid of the terminal ileum. But with nothing else beyond the liver, this mass is consistent with hepatoma. The majority of hepatomas, up to 85%, are hypervascular, more common in cirrhotic livers, though the liver does not look cirrhotic in this case, but they're typically hypervascular with prominent vascularity, and so the most likely diagnosis is hepatoma. The most likely diagnosis for the dominant left renal mass is, and the reason I say dominant, there looks like several left renal lesions, and there are also right renal lesions. Clear cell's a possibility. It's usually hypervascular. They're usually not multiple, but it can be multiple clear cells in certain syndromes, including von Hippel-Lindau. But what I'm also asking you is the appearance of that lesion, which looks spoke-like. And typically with a clear cell, which are hypervascular, you can see some necrosis, but this looks more spoke-like. Melanoma metastatic can involve both kidneys, but typically hypovascular. Papillary renal cell is typically solitary and hypovascular. A lesion that can be vascular, that has a spoke wheel appearance, and I said concentrate on the dominant left renal mass. And with that spoke wheel appearance, renal oncocytoma is the best diagnosis. Renal oncocytoma can be multiple, which was the case in this patient. And because oncocytomas are not very aggressive, this patient was being followed. In this patient with abdominal pain and fever, the most likely diagnosis is, well, I see a large solitary liver mass. The mass is cystic and solid, but it has multiple cysts within it, what you would want to call daughter cysts. There's some rim enhancement. There's no underlying cirrhosis. It looks like only one big lesion, and on the limited images I have, I don't see anything extrahepatic. Now, amoebic abscesses are possibilities, but they're typically cystic, no septations, typically in the right lobe of the liver, right lobe posterior, and usually smaller in the 3 to 5 centimeter range. Biliary cystadenomas, they're now called mucinous cystic liver masses, can be large or cystic. We look for solid components because we worry about that cystadenocarcinoma. But here there are so many daughter cysts present, that's not the appearance of the classic biliary cystadenoma or even cystadenocarcinoma, so I don't like that possibility. Metastatic ovary to liver occurs, and the mets can be cystic. Remember, cystic mets, you think ovary, you think GIST tumors as two good examples. But again, the multiple daughter cysts bother me. It doesn't look like that with ovarian cancer or with GIST tumors. You often can have multiple lesions, sure, but not one big lesion with multiple internal daughter cysts. And so the best diagnosis and the right diagnosis is Hydatid disease. What makes this a bit atypical, 70+% of Hydatid disease has calcification. You don't see calcifications in this patient. And Hydatid disease can be single or multiple. It can be extrahepatic and almost involve any organ. But this was Hydatid disease, a really nice example. The most likely diagnosis in this patient with recent onset of hypertension is, well, what you can see here on both the axial CT and on the PET scan is about a 2 centimeter mass in front of the aorta, very bright on PET, and I see basically nothing else. Bowel looks good. Kidneys, as we see them, look good. Now, lymphoma is a thought, right? But lymphoma usually has bigger masses, multiple masses. This patient, I did not say had been treated. So lymphoma, I would like to see more. So that's the problem with that diagnosis. Germ cell tumors, same thing, usually large, retroperitoneal, cystic and solid masses, very bulky, can look very much like lymphoma. So I don't like that. Castleman's disease, usually hypervascular, not quite periodic region, more in the mesentery. But you know, Castleman's can be anywhere. Their size, 2 to 5 centimeters, usually solitary, but can be multiple. but they're usually not so bright on PET scan. Now, the other thing you have to think about in this case is location. Where I'm showing you this mass is just above the aortic bifurcation, which is the region of the organ of Zuckerkandl. In the organ of Zuckerkandl, we always think about extra-adrenal pheochromocytomas. Remember, extra-adrenal pheos are about 10% of cases. Organ of Zuckerkandl is a great location. They're positive on PET. Usually they're more vascular, but this case does not have a great vascular injection. It looks more like late venous, so that may explain why it doesn't look very vascular. Often it's larger, but it's a great location. And when you tell me the patient's hypertensive, I got to be thinking about an extra-adrenal pheo. The patient's various hormonal levels were elevated. So in this case, the metanephrines were elevated, so you knew the patient probably had a pheo as the cause of the hypertension, and so this was operated on. This was a pheochromocytoma of the organ of Zuckerkandl, a really uncommon case and a very uncommon presentation in my experience. Well, those are 10 cases. Our first quiz of the year with 10 terrific cases. We have 11 more quizzes to follow in 2025, and we hope you learn from all the quizzes. We hope you enjoy them, and we hope to see you back next month. Have a great day, everybody. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.